Welcome. I'm Dr. Satish Nadig, Chief of Organ Transplantation and Director of the Comprehensive Transplant Center here at Northwestern Medicine. And I'm joined today by four of my colleagues from Northwestern Medicine Kidney Transplant Team. Transplant surgeon, Dr. Vinayak Rohan. Transplant surgeon, Dr. Derrick Christopher. Transplant nephrologist, Dr. Akansha H. Agrawal. And transplant nephrologist, Dr. John Friedewald. In today's podcast, we're discussing kidney transplantation and how recent breakthroughs at Northwestern Medicine Organ Transplant Center are leading to better patient outcomes. New opportunities for collaboration and pathways to transplantation for patients who previously were left with no options. With that, let's jump in. Dr. Agrawal, what's so special about Northwestern Medicine's approach to our living donor program, and how do we support faster kidney transplantation?
Thanks, Satish. That's a great question, and actually a perfect place to kick off the conversation. I think what's most special about our program is that we have a dedicated living donor transplant team. So our amazing team, which has our transplant coordinators, donor facilitators, social workers, and donor advocates, work really closely with the nephrologists, surgeons, and the immunologists with a special interest in living donor transplant. And so what this does is it makes the process as streamlined and efficient as possible while also improving patient satisfaction. The way we approach living donor transplant is that we discuss all the options with the recipient at initial contact. But what's great is that we actually offer some support and resources to help patients find a living donor. So we partner with organizations like the Transplant Village. We host a donor champion program, a transplant buddy program, in addition to providing donor, recipient, and caregiver support. We can also help them set up a web page, so that helps them share their story with a larger audience and helps them find a living donor.
Yeah, I always say that transplantation is the epitome of man's humanity to man. People are good to each other in life or in passing, and living donation is really exemplifies that. What are some of the advances that Northwestern Medicine's living donor program has made?
So I think our ultimate goal, right, is to help everybody find or help all the patients receive a living donor transplant. But we want to do it. We want to make sure that they're getting the best kidney possible in terms of the most compatible kidney with regards to HLA and blood type matching, age and size matching, mitigating the risk of infections by avoiding EBV and CMV mismatch. So in order to do this, we encourage all our donors and recipients to enter the paired exchange program. What this does is it affords unique opportunities to the recipient by, widening their pool of potential donors, which helps them find that best match. It's also good for donors. It can amplify their wonderful gift of donation, and it provides them with it makes them eligible for some additional donor protections and resources. For the transplant community, this means that we're increasing the chances of finding a donor for some hard-to-match donor-recipient pairs. And a lot of our patients and donors have actually already benefited from this strategy, and we continue to grow the program by sharing our experiences and our knowledge with other transplant centers.
I think what's really neat about that is it's not kind of a one-size-fits-all or one approach for every patient that comes through, because every set of patients bring their own kind of unique qualities, whether that be within their own family, within their own social network, and each of those really allows the patient to potentially channel to find that living donor, whether it be, that direct match versus a paired exchange program, or even find someone they don't even know, right, through social media and other avenues as well. I think it's really important because all of our patients come, with a different set of needs to begin with.
So just to be very clear, even if a donor is compatible with their recipient, they'd still go into this paired exchange?
That's what we'd encourage, because even though they're compatible, maybe there's a better donor out there who's even a better match or better in terms of a younger donor or a better size match. So there might still be some potential advantage to entering the pool.
I can say, it's been amazing. We've seen the evolution of living donor transplant. When we first started doing kidney exchange in the U.S. 20 years ago, we were looking for hard to match pairs and trying to get them a match. We now have evolved to a point where all pairs go into the kidney exchange program because almost everyone can potentially benefit from finding a better size matched or HLA matched donor that will hopefully give them a longer and better graft survival.
So what do you say for the patient that, the donor comes forward and says, look, I really just want my kidney to go to my recipient. How do you address that with the donor?
So I think what we're telling our donors is that they're actually stepping forward to donate for their potential recipient and not necessarily to their potential recipient. And we introduce this idea pretty upstream in the evaluation to both the donor and the recipients. And we drive home that this is to both their advantages, right? Ultimately, the donor wants what's best for their recipient. They want the recipient to do well. They want the recipient to get a kidney that's going to do them well. And they also want their donated kidney to do the most good. Mm-hmm. And I think most donors see that and they recognize that.
Yeah.
And doesn't the kidney donor paired exchange give you some donor protections also?
Correct. So participating in the paired exchange program, even if they ultimately end up donating to their intended recipient, does make them eligible for some additional donor protections.
I mean, philosophically, I think it's not the intention for a person's organ to go to that patient. It's their intention to donate on behalf of the recipient, right? And so this way they can potentially help multiple patients as you're delineating. So how has this really improved outcomes? You touched on this a little bit in this living donor space.
I think we're seeing, like Dr. Friedewald said, we're seeing our recipients get matched with kidneys that are very well matched with them, which has the potential to increase graft survival or make their kidney last longer.
And what's interesting is it's a numbers game, right? So the more pairs we put in the kidney exchange program, the better matches we can find. It's simply math. And as this network grows with hospitals all around the country, we're finding, better and better matches that we never thought we could find at places, sometimes across the U.S.
So it's interesting. We're talking about the spectrums of kidneys that are out there. And we think that, on one side, you have living donor kidneys, which could be considered the gold standard, really offering the best outcomes. But, on the other hand, we have a real problem in the United States today. About 40% of our organs are being discarded and we're not able to utilize them. There's been some advances, and I'm going to turn to Dr. Christopher here, in normothermic machine perfusion of deceased donor kidneys. I'm wondering, Derrick, what are the latest advances in normothermic machine perfusion, and how are we using them at Northwestern Medicine?
Yeah, so this is something I'm really excited to chat about. We have used hypothermic or cold perfusion in kidney transplant for quite some time, and it has really helped us be able to transport organs longer distances, allow for longer cold ischemic times, and as more universal sharing has occurred for kidneys, we know that all of those kidneys are now traveling longer distances, and sometimes they're getting turned down initially, and ultimately, by the time that our recipients are coming eligible for those kidneys down the list, that cold time sometimes plays a huge factor in this discard number. And I share the concern that, discarding 40% of our organs is a tragedy. So normothermic perfusion is a technology that essentially uses a warm perfusate that includes, blood and other products that's pumped through the kidney in order to kind of assess its viability. We've partnered with a private company that works in conjunction with the organ procurement organizations and basically takes difficult to match kidneys or kidneys that otherwise would be orphaned and are able to essentially warm perfuse the kidney for a period of time that then allows them to develop a scoring system that has ultimately shown to tell which of the kidneys they're perfusing actually could potentially have some good outcomes associated with that. It's been used through several transplant programs, including ours, in the country with great outcomes. And it really helps us in identifying some of those more difficult to use kidneys, as well as kidneys that may have a longer cold time that we otherwise wouldn't consider, because once they place it on normothermic perfusion, then we potentially resetting the clock in some ways in being able to get our recipient in, perform the cross match if necessary, and all those other things that come along with adding cold time that would sometimes in the past have made it challenging to be able to transplant.
Can I just say there's a lot of press about studies in Europe saying they discard so many fewer organs than we do, but they have a much smaller landmass to deal with, and logistics aren't as big a problem. And so this is a really unique way to probably solve one of those problems, is that we've got a lot of land in the U.S. and shipping organs around sometimes is impractical. And so this is a real hope for being able to utilize some of the kidneys that would be and do well if it weren't for the cold ischemic time.
It's actually exciting. Like you can actually, the cold time to a large extent, you can mitigate the cold time, which was otherwise we are always working against the clock. And I think this is exciting that this technology, we are able to overcome that.
Do you think that these types of platforms set the stage for what the future might look like for kidney perfusion, potentially with therapeutics?
Yeah, I think, anytime we start talking about warm perfusion as well as therapeutics, it really adds kind of the next level of what we think about in kidney transplant. We know that, the kidneys that we get that are being utilized both at our centers and other centers have hit their proverbial limit as far as if we get those organs immediately, we know that we can transplant them. We're not worried about those organs. And so it's more so, how do we deal with some of these organs that either have some level of concerning disease that we may need to mitigate, like an ATN process or whatnot, or perhaps other kidneys that are just, as we've all said, been around trying to be placed for a number of hours, and then in order to get that organ to our center to actually be able to use would kind of put it over that limit. And so being able to take that away and kind of reset the clock, as you said, Dr. Rohan, is outstanding. And then ultimately start thinking about some of the additional technologies and therapeutics that are kind of slowly growing as well, and then combining those platforms together really makes me excited about kind of how we can utilize this technology going forward.
Does it shorten the wait time at all for people? I guess we should start with what is the average wait time for people waiting on the list. But in addition to that, do these technologies shorten the wait time?
Yeah, that's a great question. I think, anytime we're talking about wait list times, there are a wide-ranging number of reasons why individuals' wait times may be different, anywhere from our living donors who may get a preemptive transplant to some of our preemptive patients who are able to stave off dialysis for a longer period of time versus our individuals who are on dialysis. And so the way I would answer this to the average patient is, we know that the average wait time is somewhere between 5 to 7 years, but that number can hugely vary, where we have patients who, as I mentioned before, are already transplanted prior to even starting dialysis versus patients who have been on dialysis for 19 years. And we are finally getting to them because of, HLA issues or otherwise. So I think because of that wait time, utilizing these kidneys potentially offers us a way to allow us to transplant more patients, which then hopefully in the long term means that wait time gets less.
So what do you think is, you mentioned there's a handful of centers in the country that are using these technologies. What's keeping it from going mainstream?
Yeah, I mean, I think as we all know, transplant is a highly regulated field. And so just like in the rest of medicine, when there are new advances in the field, it takes a little bit of time for it to become more universally known. And I think one of the exciting things about being part of Northwestern is innovation is part of one of our pillars. And so we all around this table are very excited about kind of innovative, disruptive technologies and how that can potentially help our patients. And, obviously as a regulated, group of transplant, we have to consider that, but we are in a lot of ways, we are not kind of beholden to that, as long as we are able to kind of keep our metrics in order to transplant more patients, allows us to be just that much more aggressive.
Mm-hmm. Yeah, well said. I always joke that, I recently bought an electric vehicle that has sort of a fully self-drive feature on it. And I I'm not touching the steering wheel as it's driving. And then I had to go give this talk. I go give the talk, not touching the steering wheel, come back, and then I see a patient in clinic who is eligible for a trial that we're doing at Northwestern that's really out of the box and next generation. And at the same time, we're robotically implanting a kidney. So, technology is all around us. And you're right. It's a lot of times medicine changes, but physicians are resistant to change. Yeah. And I think that the group has been really deliberate about adapting and embracing a lot of these changes in a fast-paced world of transplant. Speaking of that, Dr. Rohan, the first transplant was done in 1954, and Dr. Joseph Murray won the Nobel Prize for that. And since then, there hasn't been too many advances in the actual technique of transplantation. You've really spearheaded this idea of potential for outpatient kidney transplantation. I mean, is this real?
No, it's exciting. At least that's the whole goal, right? Like, you want to try to improve upon everything what you are doing. We have been doing kidney transplant the same way technically for many, many years. We have had good outcomes. Today, our outcomes are fantastic, but we always see what we can do better. So maybe 2 years back, we came up with this idea of awake kidney transplant, which kind of stands for accelerated surgery without general anesthesia in kidney transplantation. So idea is the patient gets spinal anesthesia, and we integrate it with the ERAS protocol, that's Enhanced Recovery After Surgery protocol. So by integrating these two, our goal is, can the patient recover quickly? So we started with our first patient maybe 2 years back now. That went fantastically well. And over the last 2 years, we have done more than 20 awake kidney transplants. And today we can see that a subset of patient, well-selected group, we are able to discharge within a day after the transplant, which is, if you really see it, unthinkable even a few years back. And general average stay for most of the transplant programs in the country is like 5 to 7 days. So today we are able to send patients home within 23 hours. That's fantastic.
Is that safe?
We have shown it's safe because we have done it for the last 2 years now, and we have maybe the highest number of patients who are on this protocol, and we are the only program in the country who have implemented this awake program.
Mm-hmm. And what do you say to the patients? We often get patients that say, well, knock me out. I don't want to be awake during this operation. How do you address that?
At the end of the day, choice of anesthesia is patient dependent, but I can always tell the patient there are certain advantages of getting a awake kidney transplant. One, your recovery is going to be faster. You are going to eat faster. You're going to move faster. You're going to get around the hospital faster. You're going to get discharged faster. And from our trial, what we realized was our pain control in this patient is phenomenally good. Most of the patients did not even require opioid analgesics. Out of 20, maybe 2 patients required opioids as an inpatient. That is nearly unheard of if you really see the whole kidney transplant population. So if you want to get well quicker and faster, this is a great technology.
And it's interesting. I think
I would say that one of the things that's really cool is, while our numbers are obviously not as big as multiple other populations, the part that I think that we know exists are other specialties in which have kind of rolled this out and their ability to transform inpatient surgeries to outpatient surgeries. So I think, having this model of kind of stepwise getting to that approach is one that we know exists, and obviously we want to be safe about it and thoughtful, but for the patients that have interest and are able to do that and their preferences, it makes a lot of sense.
I still remember one of our early awake transplant patients who was transplanted on a Friday. I was rounding on the inpatient service. I walk in Saturday morning, right? He's 18 hours from surgery. He's eating the Saturday special blueberry pancake breakfast. Pain score is 0. All his bags are packed. He's like, I was just waiting on you. Can I go home? And he got home that day sooner than I did. So
that's phenomenal. That's amazing. That's phenomenal.
I'll say as the old guard here at the table, having worked at the Northwestern Medicine transplant program for 20 years, we shift paradigms, and whether it's steroid-free immunosuppression, and people thought we were crazy for that, and now it's become the norm around the country. And I think it's thinking outside the box, believing you can do it, and then convincing everyone that it's okay, and showing them it's okay. And we've done that over and over, and that's why it's so fun to be part of this program, because everyone here takes a mindset of innovation that at the end of the day is driven to improve patient care and make their lives better.
Yeah, I think, you said it, and Dr. Christopher, you mentioned it as well, really embracing these sort of disruptive technologies, and it's become kind of the ethos of Northwestern transplant. Would you all agree? I think it's become something that really we have made as part of our fabric. A lot of times it's how we address it to patients that make it a little bit more palatable. And so if you think about it, women are having C-sections every day under spinal anesthesia, and hip replacements and joint surgeries done under spinal anesthesia. And I think that the word awake can sometimes be jarring, but it's actually that, they're in a twilight, they're in a colonoscopy, they have no pain, and the operations tend to be much more streamlined. So what are some of those advantages intraoperatively?
So I think there are two kinds of patients we think will benefit the most. There are a subset of patients who are considered high risk for general anesthesia, which we think will benefit a lot. Now we're getting a lot of referrals from outside. There are patients who are allergic to general anesthetic drugs. There was a patient who basically had an allergic reaction and nearly coded, and now this patient has come to us. And there are patients who are having upper airway issues, who are very high risk for general anesthesia. So these patients, it will help a lot. And there is young people. There are a lot of other people who can recover so much quicker from this surgery and get well soon. So I think so it basically increases the access for transplantation. It improves the recovery, and it just makes the whole transplant journey smoother.
Yeah, I mean, our anesthesiologists are great, right? I mean, they're able to do all these amazing things, and we couldn't do the work without them. But there are plenty of patients, that have risks. I mean, we know anesthesia has risks. And so we have that subset of patients, both in transplant and outside, who do amazing from whatever surgery is performed, but unfortunately have side effects associated to anesthesia, whether it be nausea or other allergies or other things that go on. And so, just like anything else, if we can help mitigate those risks, then we only stand to the patients only stand to benefit.
Yeah, and we have a large multi-organ transplant program, including a lung transplant program, and a lot of these patients will, because of the anti-rejection medication they get, will often need kidney transplants because it's toxic, and if we can keep them from being intubated, that's another potential opportunity.
Yeah.
And we talked about organs to select prior to transplant, whether it be living donor or those marginal organs that go on a normothermic perfusion pump. We talked about intraoperatively some of the changes we made, but now I want to switch gears a little bit to you, Dr. Friedewald, a pioneer in the postoperative care, where the standard of care now is to poke needles into the kidneys to get biopsies to look to see if somebody's rejecting, and then having to up those medications, and that can have side effects that we just talked about. You're really a pioneer in non-invasive monitoring of kidney transplant recipients using biomarkers. And how is Northwestern Medicine using these non-invasive monitoring techniques in kidney transplant recipients in innovative ways?
Yes, Satish, it's a great question. It really started with the observation that we wanted patients to have one kidney for life, and that wasn't the case. Kidneys last a certain amount of time, but oftentimes we find they get rejected over time from chronic rejection. And so we started to say, well, a lot of those patients had pretty stable kidney function, and we used to monitor the kidney function and say everything was fine. And then we started to do surveillance biopsies, as you mentioned, and found that about a third to a quarter of patients could be having rejection, what we call subclinical rejection, with normal kidney function. And I liken it to a house on fire that hasn't fallen down yet, but it's still standing, but having a lot of damage. And so we started doing biopsies on all our patients, and they do it in heart transplant and lung transplant as well, but they're invasive and expensive and uncomfortable. And so our goal was to try to come up with a non-invasive way to monitor kidney transplants without needing to do biopsies. And so a number of different, we call them non-invasive biomarkers have been developed over time, some with the help of our team here at Northwestern Medicine, blood tests that can tell us whether there's the presence or absence of rejection without needing a biopsy, or informing who needs a biopsy. So we can avoid biopsy safely in about half of patients that have negative biomarker tests. And so now we routinely use these as part of our surveillance strategy and a rejection monitoring strategy to avoid biopsies in low-risk patients. Some patients still need biopsies, but we know that if we need to do a biopsy, it's for the right reason, that they're likely are having rejection. And the good news is we can often treat that by adjusting immune suppression. And so the field now really has evolved to using these tests now routinely. And a lot of that started with our team here at Northwestern Medicine. Very proud to be part of that.
No, I mean, that's great. I think that, it's the program, and you have been really a pioneer on the front edge of biomarkers, and it's really created some new opportunities for successful outcomes. Can you delineate some of those opportunities potentially?
Yeah. One of the things is, and I talk about the Goldilocks dilemma a lot, that when we have a patient on immune suppression, we want the levels to be just right, not too hot, not too cold. And the problem is that we can now detect when someone's on enough immune suppression, and we can intervene and give them more, but we didn't have a good test to monitor too much immune suppression. And another thing that we've helped advance here at Northwestern Medicine is the following of a virus called tortenovirus, which is a virus that most people have. And if you're on too much immune suppression, the levels of the virus go up. And so it's almost like a thermostat or barometer for the immune system. And so now we're working to combine these rejection biomarkers with other viral kinetic monitoring to know if someone's on too much, not enough, or just the right amount of immune suppression. The idea is to keep patients right in the middle in a safe level of immune suppression where they're not rejecting the organ, but not at risk for infections or malignancy, which is the side effect of too much immune suppression.
I mean, if you think about it, it makes so much sense. I mean, up until now, we have been treating immunosuppression like shoe sizes, like they all sort of fit into a particular category, but each person is different and each person wears a different size shoe. So they should be personalized. What's next then for biomarkers? What's sort of on the horizon?
Yeah. So we're really getting into an era of precision medicine that, the cancer field has led the way with, and now we're entering that in transplantation. So we now have a number of different biomarkers to monitor the kidney. We're now working on better ways to combine those using artificial intelligence, combining traditional tests like urine protein and creatinine and all the things we are used to, now including cell-free DNA and gene expression biomarkers and urine chemokines and the viral kinetic monitoring. And what we're building now are predictive models where we can have predictive risk assessments based on each new piece of information that comes in, whether it's a urine or blood test, that can update the risk of rejection for a patient and interface with our EHRs to tell us that someone's rejection risk may have just doubled based on a result, a cell-free DNA result that just came back, for instance.
And so, it's interesting. We talk about too much immunosuppression, and you've alluded to some of the side effects of immunosuppression. We think that everybody needs immunosuppression. With some of your discoveries and how you're implementing these biomarkers, not everybody needs the same amount of immunosuppression. Are there people out there that really don't need immunosuppression at all? And what's Northwestern doing about that?
Yeah, good question. So first of all, yes, one of the real practical uses of these biomarkers, because you can do it non-invasively and repeatedly, is you can wean someone's immunosuppression to what we think is a safer level and monitor them in a way we could never monitor them before, number one. But I think what you're hinting at is obviously getting patients off immune suppression completely, and we call that tolerance. And Northwestern Medicine has really led the way internationally on this. Some of the work of our colleague Joe Leventhal, doing a number of different ways to induce tolerance, whether it's combined kidney and stem cell transplants, now working on protocols to infuse T regulatory cells that can be expanded ex vivo and given back to a patient to reduce the need for immunosuppression, getting
the
down
discovery
to
of which
drug.
won the Nobel Prize just about 8 months
That's
ago.
right. That's right. So it all builds on the basic research, and we take it to the next level and translate it. And so, yes, Northwestern Medicine has one of the largest cohorts of tolerant patients living with a healthy kidney transplant and no immune suppression, some up to a decade after the original clinical trial. So it's exciting stuff. And there are a number of trials still ongoing here to push the field even further.
Well, I think when it comes to the next frontier of transplant, Northwestern Medicine is really on the leading edge, whether it be living donation or use of normothermic machine perfusion or doing the transplant awake and sending somebody home the same day, or getting people off immunosuppression, or personalizing their immunosuppression with biomarkers. So we've talked about a lot of different things today, but I think that the core of it is truly we're a destination center for transplant innovation. And I could not be more blessed to be around a group of colleagues like all of you who are my work family. And that wraps up our discussion today. And I really want to thank you all for joining and sharing the exciting advances happening here at Northwestern Medicine in the field of kidney transplantation and beyond. To refer a patient or get more information about Northwestern Medicine, visit our website at breakthroughsforphysicians@nm.org to connect with one of our providers. Thank you for joining us today.
Thank you.
Thank you.
Thank you.
Thank you.